Thank you very much for inviting me. It's really a pleasure to be here. Thank you all for coming. I don't have to preface my talk by saying this is something uncommon. This is something very common that you will see very soon. I'm on call for our group backup call this weekend, and I may see it even today. So this is something that comes up quite often if you see adults. If you only see children, maybe not so much. But I am a geriatric psychiatrist, and my interest is in neuropsychiatric symptoms and neurodegenerative disorders. And I'm speaking on the assessment and treatment of neuropsychiatric dementia. Oh, I think I forgot my slide, but I recently consulted with Ionis and Biogen, but that doesn't affect what we're talking about here. So what I wanted to talk about for the next 35 minutes is just understanding the course of neuropsychiatric symptoms, especially Alzheimer's disease being the most common cause of dementia, and then understanding kind of the approach or my kind of tips on the approach and treatment of these very common forms. So, I don't know, when you guys went to medical school. When I went to medical school, I would argue that kind of the way neurodegenerative illnesses were presented to us is, well, you have Alzheimer's disease, which is a cognitive disorder, and you have Parkinson's disease, which is a motor disorder. I would argue that the view of the field has changed on that. And so now, not that they're not quite motor disorders, but that most of these neurodegenerative disorders are multifactorial. So they will affect, so Parkinson's disease will have cognitive effects often, and that most of these disorders will affect behavior, emotion, higher complex behaviors and things like that. So as opposed to kind of saying, well, Alzheimer's disease is a memory disorder, which very rarely you'll get some neuropsychiatric symptoms, I think the move has been to more that neuropsychiatric symptoms are a part of the illness, an inherent part of the illness. And how common are neuropsychiatric symptoms in Alzheimer's disease depends a little bit on how you define them. I would argue that if you define broadly and over the course of the entire illness, so broadly meaning including apathy and less interest in usual activities, I would argue basically almost all patients with Alzheimer's disease will at some point have some neuropsychiatric symptoms, and they can be in range. So some people here at Columbia have done some really interesting work on some important practical questions. This slide is about, what the common question people will have, I'm sure to you, when their loved one is diagnosed with Alzheimer's disease, is how long can they be at home? And it turns out neuropsychiatric symptoms are one of the important determinants of that. So people with agitation, psychosis, wandering, much harder to have them at home. It really affects that. So it actually greatly increases the cost to the nation of treating Alzheimer's disease. And, I was joking before about being on call, but, I'm sure in your practices you see, the chronic memory problems of Alzheimer's disease obviously demand attention and diagnosis and treatment, but they're often not quite as emergent. The calls you get kind of often over the weekend are agitation, someone's hitting, someone's, those are often the ones that you're dealing with emergently. So, there's a range of neuropsychiatric symptoms, and I would argue, one thing that does differ pretty fundamentally between neuropsychiatric symptoms and the non-neuropsychiatric symptoms, cognitive and motor symptoms or degenerative disorders, is that they're not all linear. So, for example, we think of cognitive symptoms in Alzheimer's disease. No one's memory gets better over time with Alzheimer's disease, whereas certain neuropsychiatric symptoms can wax and wane. So it's actually agitation. As apathy increases, agitation can decrease on its own. Well, I'll talk a little bit. Depressive symptoms can decrease. So the time course of neuropsychiatric symptoms in Alzheimer's disease is complex. And it's not as simple as, say, memory and Alzheimer's disease. Again, we don't think of it in Parkinson's disease. We don't think of motor symptoms as getting just better over time, but that can happen. Here I list some of the most common neuropsychiatric symptoms: agitation, aggression, which can be different. Agitation usually meaning just the patient being very upset. This can often be very upsetting to families as well. Aggression meaning turning that upset outward and hitting and can be violence towards others. Delusions, so believing things that aren't true, and as you guys again probably have experienced all of this and know this, but often the delusions of Alzheimer's disease are tied into the memory symptoms. So people are moving my things, people are stealing from me, people are shifting things around without my knowing, and really what's happening is they're moving things, they're forgetting where they put things. Delusions and paranoia and psychosis are often very linked to agitation and aggression. So, if you think someone's breaking into your apartment and moving your things, it's very rare to have a patient who isn't upset by that. And then many who kind of want to take matters into their own hands and fight back. And so often these symptoms are kind of intertwined together. Depression, we'll talk a little more about, very common in many neurodegenerative disorders. Insomnia and anxiety as well. This is, a couple slides here just on the course of neuropsychiatric symptoms. This is a study done by a colleague of mine, Dr. Devanand, over here in the Psychiatric Institute, right down the block, where they did, I'm a big fan of this study. What they did is they just followed patients with Alzheimer's disease over time, and they said, what neuropsychiatric symptoms they have at different stages. And it's nice because it is actually longitudinal, it's not cross-sectional. We took these patients, mild and moderate, and then just every 6 months follow them over time. So this study on the CUSPAD, which was a measure they were using in neuropsychiatric symptoms, at baseline, the majority had at least one symptom, sort of backing up what I'm saying that these symptoms aren't very common in Alzheimer's disease. And they followed them for 3 years, and less than 10% remained neuropsychiatric symptom-free over that time. So again, the vast majority of patients developing some sort of neuropsychiatric symptom over 3 years of follow-up. This is just, I have a couple of graphs just showing the prevalence, and I'll dive into it a little more too, but paranoia, which often had a kind of two peaks. One was very early in the illness, and then one was as it got more severe, but getting a little better in between. Hallucinations, also a little more of a late problem than an early problem in Alzheimer's disease, so the prevalence of hallucinations increased over the course of the following them. But not that common, so not a very common neuropsychiatric symptom in Alzheimer's disease, as you can see. Agitation, you can see, quite common. So reaching at one point, at 2.5 years of follow-up, the majority of patients having some agitation or wandering. And again, generally sloping up. So generally, the more severe the Alzheimer's disease, the more agitation they have. And aggression, physical aggression, showing a similar pattern. Depressed mood, and the slide, it doesn't capture it quite so well, is actually a little bit bucks the trend, in that depressed mood is actually usually often an early symptom in Alzheimer's disease. So I, as a geriatric psychiatrist, will often see patients with mild cognitive impairment or early Alzheimer's disease where we're treating depression as well. And we now know that in many cases, late onset depression actually is Alzheimer's disease. So when patients present without a history of depression and then a new onset depression late in life, often with prominent cognitive symptoms, so complaining a lot of trouble with memory and concentration, but really having quite depressed mood and meeting criteria for depression, often that will meld into an Alzheimer's disease. And those are patients where the kind of the neuropsychiatric presentation is really the initial presentation of the illness. They're presenting with dementia, and that's their version of Alzheimer's. I have found, and again, it doesn't come across in this slide so much, but that a lot of my, several of my patients with Alzheimer's disease do what I call kind of dementing out of depression, where depression is initially a very strong complaint. We work on it, we treat them, and then several years, more years into the illness, I'm looking over my notes, and we're just not talking about it so much. In other words, we move more into agitation as a problem, or these other problems that I mentioned, and they're complaining less and less of actually depressed mood. And some of that, I think, is that you can kind of dement out of depression in some ways, where initially it's a very early and strong symptom, but then as they move into the moderate stage of the illness, how do you find yourself in the family? They're not talking about it so much, and they're not. And that probably is due to the fact that those areas responsible for the perception of mood are becoming damaged as well, so that they're not actually feeling. And it'll often be taken over by apathy. They become more apathetic and less actively depressed. So just to summarize kind of the course of neuropsychiatric symptoms in Alzheimer's disease, most patients will develop some neuropsychiatric symptoms. Psychosis and agitation are very hard for families, very hard to manage at home. It will often lead to institutionalization. Agitation and aggression increase as the disease progresses, so the more severe the disease, generally more often we have them. And then depressed mood, it says here rarely persists, but depressed mood can actually decrease over time in Alzheimer's disease. So summary continued, Alzheimer's disease, I think I've said this several times, but it's a neuropsychiatric as well as a cognitive disorder. And before they needed that time, and then the symptoms develop and change over time. So, one clinical implication of that is it's often a moving target. You just kind of get on top of something, and then the next visit the family comes back and says, well, that's not a problem anymore, but now this is a problem. So it's kind of, you always got to be light on your feet if you're treating these disorders. So let's shift a little bit to kind of what do you do to address or treat these symptoms. Agitation psychosis, again, just giving you some data, 11% in mild cognitive impairment, so kind of preclinical very early Alzheimer's disease, and when they have full-blown dementia, about 30% of people will have agitation psychosis. So, one thing I'll stress throughout is the importance of non-pharmacologic interventions, that they can, for all of the neuropsychiatric symptoms, they can be very important. So, things like the setting. So, one thing whenever a patient comes in, I'm addressing is, can they be at home? Or is this just too much for people? Would they be better served in an institutional setting? I think that's something to think about when you see people. So for example, I see a lot of non-Alzheimer's dementias, and that's kind of my particular specialty. And I saw a patient with FTD, who was frontotemporal dementia, and he was being very sexually inappropriate with the children. Often people with FTD are younger, so the children were young. And so the first thing when I saw a family come in, I said, I don't think this is appropriate in a home setting anymore. I think this is doing more harm than good. And a lot of families are very attached to, I want them at home. I don't want to, institutions are bad. But as clinicians, we kind of have to give them our judgment on that and say, I think it's time. And they'll often look to us for that. So that's often in an algorithm when I'm seeing a patient. One of the first things I see, sort of like, they teach you in medical school, does this patient need to be hospitalized? Or is the first question, are they doing okay at home, or is it time to question that? Home health aides. So, a lot of neuropsychiatric symptoms, even if you ameliorate them, spreading them out can help a lot. So sometimes someone will have a neuropsychiatric symptom, let's say agitation, and part of the problem when they come in is that a family member is with them 24 hours a day dealing with it. If they can get a break, you can often both working on reducing the symptom, but then also give them a break, spread it out a little bit, and a lot more tolerable. It's a lot more tolerable to deal with some of these symptoms for 4 hours at a time than for 12 hours at a time. So that's another thing I kind of look at when I see someone. Behavior logs, I encourage this in all the families, because often the families will come in and say, well, is the agitation happening at a particular time? They say, no. And then you say, well, keep a behavior log. And then they come back and say, actually, it's happening at 4 o'clock every day. Now that I keep the log, and that helps you with just medications, etc. Adjusting expectations, let me get to that when I get to pharmacologic treatment. And then physical intervention. So, a big one for that is, wandering. There's some very good products, door locks for patients with Alzheimer's disease where they can't get out. And then wandering becomes much less immediately dangerous if they can't get out of your apartment, as opposed to walking down the street. So thinking of kind of physical, so often Wander Guard bracelets also, which now often have GPS. There are many physical interventions we can do which can really help us control these symptoms without the medication side effects. So sometimes we pay lip service to the non-pharmacologic, but I think it's actually incredibly important for these patients. A common question I get, I don't know if you get this too, but is with a patient with psychosis, with delusions, and what do I tell them? Do I humor them? Do I not? I get that from families a lot. And generally what I recommend is truth but distraction. So in other words, don't buy into their delusions. Don't say, oh yeah, people are moving this around. Say, no, that's not happening. You forgot where you put that. But don't dwell on it. Just move on. Try to move on to something else. Because then what they'll do is kind of get focused on that. It can get them more agitated. So I recommend truth, move on. When people bring like delusional content. And I dissuade people from trying to argue them out of their delusions. And for most psychiatric disorders, including schizophrenia, things like that, you're really not going to make headway arguing them. But at the same time, not to lie to them. And to try to model kind of lack of agitation. The caregiver himself is calm, comforted, you're safe. This is a safe environment. Okay, so we're moving on to pharmacologic treatment. So really the one class of medications that has been supported for treating agitation, psychosis, aggression in Alzheimer's disease are atypical and antipsychotics more generally. They are commonly used for behavioral symptoms. It is now one of the most commonly, the most common usage for these medications, even though they're developed for schizophrenia and primary psychosis. We now use them very commonly for Alzheimer's disease. if you look, and there was a really nice review back in 2011, the effect size is not enormous. So generally, people, when we look at all the studies on this, people do improve, as a group, improve the behavioral symptoms, pediatric symptoms, improve on these medications. But one thing, and this is, I said, we get back to adjusting expectations, I think it's very important, and again, I would very much encourage you to put time into, is setting expectations for the family. So a lot of times families think, well, we got agitation, you give anti-agitation medication, done and done. And it's really, and you probably in your experience, it's not the case. That you can ameliorate the symptoms somewhat, often they can help, but it's rare you're going to just start them on a medication and they'll just melt away. And so to really kind of tell the families, this is a work in progress, this is going to involve a lot of tweaking. Our goal is to reduce and make things more manageable, but to redefine in a way what success is. Because I tell people, like, if they have a paranoid delusion, people are moving things. Even if these medications work, it's not that they're going to say, oh my gosh, wow, that was crazy, what was I thinking? Really what our goal is it's going to be less upsetting, we're not going to be in distress as much, they're going to be more comfortable, but don't expect them to completely, the symptoms to completely resolve on the medication. And I think that's really important because it helps you, later from them being upset and angry, saying, wait, I gave them, thinking of it like an antibiotic for an infection, I gave them the medication and they're still agitated, what's wrong? What are you doing wrong? To try to inoculate against that because it won't just go away. And also the other thing is these doses develop, these medications need a lot of dose titration and changing, so it's rare you're going to start something and it'll do similarly. Something that got a lot of press a while ago was this black box warning for the antipsychotic medications for dementia, where we looked at the data and found that patients with dementia who were put on these medications had an increased odds ratio of dying, which is obviously a serious issue. And one which your families and people will often look up online too. So I would recommend talking to them about it because I think that they from the internet. It's the cause of death doesn't appear to be so clear. One cause appears to be increased sedation, which may lead to more aspiration, especially in people with advanced dementia. But there does appear to be a higher incidence of cardiovascular events in these patients as well. I generally find it not to be a huge problem. Usually agitation, psychosis, aggression are such big problems in the family. Once you can explain that it is an increased risk, but not that much increased, and if it's warranted, considering how problematic these symptoms are, generally families can go along with you on that. But I bring it up because, again, I prefer to hear it from me than get online and say, why did you tell me about this? So what medication do we specifically choose? Generally, mostly comparable efficacy as far as we can tell between the atypical psychotics. And so we choose mostly based on, as you know, the different antipsychotic medications have different side effect profiles. And so we choose mostly based on that. So let me go over some of them. Now, one kind of take-home message about the antipsychotics, and this will be actually in contrast to the antidepressants in dementia, or Alzheimer's, which I'll tell you about, is that you go lower in antipsychotic medication than you go in, say, schizophrenia or young people's psychiatric illness. So, and there is good evidence, and again, a lot of this was done by Dr. Raman here at Columbia, that when you get to a certain dosage in the atypical antipsychotics, after that, you're really kind of just getting side effects without really improving efficacy against psychosis and agitation. And so time to rethink. And that range is lower than you would have in schizophrenia. So here I've given you kind of summaries. Risperidone really has probably the most data on it for agitation in Alzheimer's disease and dementia. Reasons we may not use it as much sometimes, or don't use it, don't pick it sometimes, has more Parkinsonism associated with it than other atypicals, especially at higher doses. It often has a twice-a-day dosing, which can actually be an advantage sometimes, depending on kind of what the pattern of agitation is. But you'll see the range here I've put is 0.5 to 2.5. Now, in young schizophrenics, you can go up to 8, much higher. But if you're getting up to 2, 2.5, it's time to reassess whether this medication is the right one. Quetiapine has less EPS often certainly than risperidone. It can be sedating, which again can be an advantage. So if people are having insomnia in addition to, say, agitation or psychosis, that can help them sleep. We use a fair amount of it. Again, the range in young people goes up to 800. Really, when you get up to 150, 200, you should be re-examining, though, whether this is the agent for you. There's the question of efficacy. If you look at the meta-analyses that have been done, and the one I cited you before, quetiapine is actually the only one which didn't separate out from placebo. And it's complicated. The drug company said, well, it was a little underdosed in those studies, but that's just what comes out of the data. But it's still, we use it a lot. Olanzapine, we can cause sedation, appetite increase, particularly interest when it's FTD. We very rarely use it in FTD because they're already usually hyperphagic. Aripiprazole, a relatively newer one, with relatively low EPS as well. There's a new medication from Advancerin, which has been approved for psychosis associated with Parkinson's disease, which is really the first new medication we've had in this class or related to this class for a long time. In Canpro QT interval, the mechanism is not fully understood, but does appear less likely to cause EPS and is generally reserved for Parkinson's disease dementia or Lewy body dementia where they failed quetiapine or another low EPS antipsychotic. Okay, this. I'm going to skip the more experimental treatments for agitation for Alzheimer's disease. So antidepressants for agitation and Alzheimer's disease, much less evidence. I mean, the evidence has really been equivocal. So there was a large review, which I have here listed, and that concluded that antidepressants are very well tolerated, but really don't appear to treat agitation much. I will use them for agitation if it's in relation to depressive symptoms. So if they say, oh, mom or dad, just gets so down and gets crying and it's so upset, gets really worked up about it. And then I think an antidepressant are very well tolerated. But if you have straight ahead agitation due to psychosis, due to, I think that you really need to go to the class that is most supported, which is antipsychotic medication. I'm not a big Depakote fan. It actually associated with I think your ratio for reducing agitation compared to adverse events is quite low. In other words, you don't get much reduction of agitation for the adverse events. Cholinesterase inhibitors, again, questionable clinical significance in agitation, not a first-line agent. So I guess we'll have a discussion period after we can talk about questions or thoughts on that. So depression and anxiety. Now, depression, point prevalence relatively high. So if you ask your patients if they have depression, as I said before, actually as the dementia becomes more severe, the prevalence of actually feeling depressed, dysphoria, crying can decrease over time, often kind of taken over by apathy. We talked about it could be a risk factor for Alzheimer's dementia. So my kind of take-home message on prescribing for depression in Alzheimer's disease and neurodegenerative disease is actually kind of the opposite, or very different from the antipsychotics. You can use the same range you use in younger people. It really should. You go slowly, so you give people time, go slow, start low, go slow, but you really shouldn't. I would argue with antipsychotics, if you're getting up to the doses I said before, you should re-examine. With antidepressants, go up to the same doses you would use in a younger person, just take your time. The response rates are lower than depression, not in the context of Alzheimer's disease here, but really a neurodegenerative disease more generally. So when people have a neurodegenerative disease with depression, the response rates to antidepressants are going to be low. So one kind of, again, non-pharmacologic issue, which I want to bring up, is that it's really important to take a good history when you're dealing, I would argue, with neuropsychiatric illnesses, because families call lots of things. And, I think that as a general kind of big picture principle, again, be aware of what symptom you're targeting, what you're targeting it with pharmacologically and non-pharmacologically, so that you can see if you're responding. And, because a lot of times when people refer to me, I find the kind of what they're describing as a symptom, how it's formulated is kind of a little vague and fuzzy. Family's upset about blah blah, but it's not really kind of. So families will call lots of things anxiety. I often think they'll call memory symptoms anxiety. So like I have people who come in and they'll say, "Gosh, Mom," not even with a memory complaint, say, "Mom, you got to work on her anxiety. She's so anxious. Like she calls me 1,000,000 times a day." And when she has an appointment, she's really anxious about it and calls me 10 times before the appointment. I keep telling her, "Mom, the appointment's at 2, I'm going to pick you up," but she just calls again and again and again. And when you probe a little bit, it's actually really a memory problem. It's linked to anxiety in the sense that the patient is aware they're having a memory problem and they're trying to compensate in an anxious way because they're scared they're going to miss their appointment. But really kind of to disambiguate that from anxiety not linked to symptom. The other thing commonly, very common overlap that families do, and I would argue some practitioners do as well, is not distinguishing one between apathy and depression, which is a big problem because we're actually better at treating pharmacologically depression than apathy. We're really not good at treating apathy pharmacologically. So it's very important to distinguish, and you guys know the difference. So depression is feeling dysphoric, feeling bad, crying. Apathy, they don't feel bad. They ask kinds of mood, fine, but they just don't want to do stuff. And that is incredibly common, probably the most common neuropsychiatric symptom in neurodegenerative disease is apathy. And you're not going to really budget with antidepressants. And so I argue that I don't even try. I think that what I do with someone, so someone will come, I'll give you kind of a case scenario. So someone comes and says, you've got to see my dad immediately. He's incredibly depressed. And I come in and see them, and he's got Alzheimer's disease. And I say, well, you feeling down? No. Crying? No. Sleeping well? Yeah, fine. If anything, he sleeps a lot during the day. He just doesn't, he used to love to go to the museum. He doesn't want to go to the museum. And so to me, what I'll do is take, for that family and say, let's talk about what apathy is. It isn't. The good news is he's not really suffering. That's the point of apathy as opposed to depression. The bad news is we really, there's really no drugs we have to improve that. And so what we talk about is non-pharmacologic, so more structured activities, because that's another characteristic of apathy as opposed to depression, is when they actually do these things, they actually usually often have a pretty good time. So if you take your dad to the museum, he'll actually have a good time, as opposed to if he's depressed, where he generally won't. But that's a very important symptom cluster, I would argue, is very important to distinguish, because if you don't distinguish it, you'll often end up kind of chasing with antidepressants over and over again, and everyone will get frustrated, and you kind of be back a year later, back when you were with the family, and nothing's not bad. Okay, skip this. This is just meta-analysis of antidepressant trials. There's very little data on kind of more formal non-pharmacologic measures. So in terms of behavior therapy, we really don't know. I think there's a lot of common sense you can do, which is kind of asking, well, what is the symptom? How can we work with it? And most of the interventions, and the ones that have shown a change, mostly have worked with caregivers. So adjusting caregiver behavior, adjusting caregiver expectations, more so than with the patients. But it's not like, and I think this would be your experience as well, it's not like we have a lot of programs out there which have shown evidence and then you can refer to. You're really doing a lot of this on your own as a practitioner. And psychotherapy is an interesting question, but I think it's very unanswered. Psychotherapy in patients with Alzheimer's disease, things like that. I'll tell you there's no data, but my gut feeling is, I will send people for psychotherapy for, say, depression at the mild stages. When they get to be more moderate, I think it's not efficacious. I can't remember really the lessons of it. But I think for mild dementia or MCI, I would say MCI with depression, I think psychotherapy would be great. Okay. We talked a little bit about anxiety, that can be very interrelated with cognitive complaints. At the same time, I was saying that anxiety can be confused as, or cognitive complaints can be confused with anxiety. The other thing we should, I think, always keep in mind is that anxiety is very intermeshed with both motor and cognitive complaints. So often families will kind of say, well, my husband is, it's all anxiety. So he can remember things okay until he gets a little flustered, and then he can't remember anything. And often, she's right. He's remembering stuff worse when he's anxious, but that doesn't mean it's just anxiety. And often people with a baseline memory problem, like all of us, you or I get flustered, we don't remember things as well. It's kind of a stress test for their memory. And we see that with motor as well. So, I don't think anything's really, wrong motor-wise with my husband because, he walks okay, but then he gets anxious or distracted, he slows down, he becomes very slow. But that can be, again, a stress test for Parkinsonism. Things like that. I have a classic example I had of that was a patient of mine had peripheral basal syndrome, which is a Parkinsonian variant disorder. And his wife was very, very kind of puzzled and frustrated because she said, something psychiatrically, something's wrong. He can walk down the street, but he can't cross the street. And so I talked to him, and he said, well, what happens is I'm walking down the street okay, and then I start to, I go across the street, I start to cross the street, and then I start to think, oh my God, I'm not going to make it. I'm not going to make it, and all the cars are going to get angry, they're going to honk at me, and then he gets anxious, and then, as a lot of people with Parkinson's disorders, he freezes, he gets anxious, and then he becomes talkative, and then, it becomes this, and so, it's this interplay where, yes, the man has anxiety, but he also has Parkinsonian, and to kind of educate families in their minds, be clear about that. Anxiety treatments, again, non-pharmacologic treatments are important. We generally rely on, we call them antidepressants, but they actually have roughly comparable efficacy for anti-anxiety medications. We try to avoid benzodiazepines because of their effects on memory and cognition. So again, SSRI or other antidepressants tend to be our backbone pharmacological treatment for anxiety. So we've got much time. Yes, there's like 4 minutes left. So I'll kind of summarize. Neuropsychiatric symptoms, very common and important symptoms of dementia. You can pretty much count on your patients with dementia having some neuropsychiatric symptoms and expect it. Interrelationship between cognition and neuropsychiatric symptoms is complex. And again, a lot of that is your role, I think, or your job is lay education for the families and kind of educating them on the complexities of these interactions. So if you have a patient who presents with a depression that then turns into a dementia, educating them that can happen, that they're interrelated. Really understand what the symptom is and what you're targeting, I would argue, so that again, when you see that patient again in 4 months, you kind of say, well, here's what we're targeting, here was our intervention, what did it affect? Integrate non-pharmacologic and pharmacologic. I think as doctors, we're obviously very well versed in pharmacology, but I would argue the non-pharmacologic interventions are very important. We get a lot of mileage out of them. And then everything changes. I mean, like I said, as opposed to just linear progression or kind of always upward progression, we see a motor and cognitive symptoms in neurodegenerative disorders. These wax and wane, you've got to be light on your feet. So you'll have patients, and I'm sure you experience this, where you're treating them for depression, and then 6 months later, it's all shifted, and now there's paranoid and psychotic, and you're treating them for agitation. Depression isn't much of an issue, but I would argue that's neuropsychiatric symptoms in this population. And then just a plug for our ADRC. Thank you.